A 54-year-old man comes to the physician with worsening of his chronic osteoarthritis pain. He is taking an over-the-counter medication, which, if overdosed, may cause combined metabolic and respiratory alkalosis. Which of the following molecules is most likely increased in the serum of the patient while taking this medication? Go ahead and pause the video and try the question yourself before we go into the solution. So to understand this question, we have to first look at the breakdown of membrane phospholipids into arachidonic acid. So on the outside of all of our cells, we have this organelle called the phospholipid membrane, which is acted on by the enzyme phospholipase A2 to create arachidonic acid. Arachidonic has two fates. The first is that cyclooxygenase or COX enzymes can convert arachidonic acid into prostaglandins, prostacyclins, and thromboxane. So prostaglandins, prostacyclins, and thromboxane. The second fate is that arachidonic acid can be converted by 5-lipoxygenase into leukotrienes. Leukotrienes in general increase bronchial tone, increase bronchoconstriction, and so many asthma medications, such as montelukast, actually inhibit leukotrienes from acting on the receptors in the lungs. Additionally, Xolutin is another medication which inhibits bronchoconstriction by inhibiting 5-lipoxygenase or 5-LOX. In terms of thromboxane, prostaglandin, and prostacyclins, thromboxane increases platelet aggregation, so in primary hemostasis, aspirin is used to inhibit cyclooxygenase from producing thromboxane, thus thinning the blood because there isn't as much platelet aggregation. There are several effects of prostaglandins throughout the body. PGF2 alpha increases uterine tone as well as PGE2, and PGE1 decreases the vascular tone. Additionally, PGE2 can run to the hypothalamus and change the temperature set point. Medications such as NSAIDs block cyclooxygenase enzymes. And most of the medications which block cyclooxygenases are nonspecific, with the exception of celecoxib or Celebrex, which is specific for inhibiting COX-2. And the reason why this is important is because only inhibiting COX-2 reduces the side effects, such as GI ulcers, commonly seen with NSAIDs, because COX-1 plays an important role in protecting the mucosa of the gut. The second thing to note is that aspirin has an irreversible mechanism of action in inhibiting cyclooxygenase enzymes converting arachidonic acid into prostaglandins, prostacyclins, and thromboxane. Now that we understand arachidonic acid metabolism, let's go back to the vignette. A 54-year-old man coming to the physician with worsening of his chronic osteoarthritis pain. So he has pain due to inflammation of his joints. Arthro means joints, itis means inflammation, so chronic osteoarthritis pain. He's taking an over-the-counter medication, which, if overdosed, may cause metabolic acidosis and respiratory alkalosis. So what ends up happening, some patients who take too much aspirin because of the irreversible mechanism of inhibiting cyclooxygenase enzymes, they experience a side effect, which is a combined metabolic acidosis and respiratory alkalosis. In terms of the molecule which is increased in the serum of the patient while taking this medication, the correct answer is going to be A, leukotriene B4, which is involved in the recruitment of neutrophils. And I'll show you why. So here we have arachidonic acid. We have COX making prostaglandins, prostacyclins, thromboxane, and we also have arachidonic acid being acted on by 5-LOX to create leukotrienes. Aspirin is going to inhibit COX synthesis and decrease the production of prostaglandins, prostacyclins, and thromboxane. So what ends up happening is that arachidonic acid concentrations increase, and the activity of 5-LOX tries to compensate for the increase in arachidonic acid by increasing the amount of leukotrienes produced. So that is why prostaglandins, prostacyclins, and thromboxanes cannot be the correct answer, because the amount of those molecules after administration of aspirin would actually be decreased.